Assalamu alaikum wa rahmatullahi wa barakatuh. Thank you so much, Dr. Muhammad, for introduction. I would like to thank also Dr. Najwa for the invitation. So my talk today about the immunotherapy in lung cancer, and I think it's one of the difficulty to go through those topics is because non-small cell lung cancer or lung cancer was one of the earlier disease that was where immunotherapy has been introduced after melanoma. So we do have plenty of data when it comes to advanced stage, and also we start to have also more data with an earlier disease. So it's quite difficult to go through all of those data within a 20-minute, but we'll try to go as much as we to give you more kind of an overview on those in a minute. So I need to go to the next slide. I think we have an issue. Yes. So that will be the lecture outline. First, I'm going to go over the data. We have a good number of data for advanced stage non-small cell lung cancer, either in first, second, as well as subsequent line of treatment. And since we do have good data that showed promising benefit in advanced stage, we start to see also more data with an earlier disease, mostly stage 3, and I will go over that as well. So when you treat patient as a clinician, we treat patient for the first time, we look at the number of molecular pathological factors that also has been described earlier by Dr. Turki, and as well as the number of clinical factors, performance, and all of this. And based on that, we classify those patients in a more kind of oncogenic addicted tumor, where we have a number of options that mainly focused on the specific target mutations, such as an EGFR or ALK or ROS1. Those represent a smaller proportion. However, those proportions are getting larger as we move on. Majority, or probably we are reached to half of those patients, are non-oncogenic addicted, and in those patients, the options that we do have right now is immunotherapy, either a monotherapy or as a part of combination treatment with chemotherapy in particular. The initial data that we have probably in those patients with subsequent treated, those who are heavily pretreated patients with many lines, and a number of checkpoint inhibitor has been checked, Nivo, Pembro, Atezo, in patients who has been heavily treated with chemotherapy. What we have seen with those trials is the response rate that has been achieved with a single agent monotherapy or checkpoint inhibitor. It's kind of 20% range. It's not that high response rate. But what's really important to keep in mind, and what's really make those options as a breakthrough treatment in advanced lung cancer and probably in also a tumor, is the response that has been achieved is more kind of durable response. On the other hand, what we have noticed also is the safety profile. Those drugs are quite safe. The toxicity is nothing comparable with the chemotherapy, which is the standard treatment that we have before the immunotherapy. The other important finding that we have seen, and that's with a longer follow-up, since immunotherapy has been introduced more than 5 years, and we start to have 5 years data that's already presented probably 2 years ago. One of the earlier trial that look at the checkpoint inhibitor, one of the checkpoint inhibitor Nivolumab in patient who has been heavily pretreated with chemotherapy. We have seen that almost a quarter or 15 patient, more than 15% of patients they were alive at 5 years. This isn't something we haven't seen really before, and hardly you see, or less than 5% of patients with advanced metastatic non-small cell lung cancer will be alive at 5 years. So 15 or more than 15 years is something we haven't seen for decades. Giving them the promising data that we have with the subsequent treatment, many clinical trials that has been conducted in a second line treatment compared to the standard control arm, which is the chemotherapy in form of docetaxel. And we have number of trials with almost similar design. The only difference is which checkpoint inhibitor, BDL1 or BDL1, BD1 or BDL1 inhibitor in patient who has been failed platinum-based doublet, whether squamous or non-squamous. And in fact, we have number of trials that make the standard of care as we have right now. We have data for Nivo as a checkpoint inhibitor. We have data for Pembro, Atezo, and the Nivo we have two separate trials for squamous and non-squamous regardless of PD-1 expression. We have atezo compared to docetaxel regardless of PD-1 expression, and we also have a pembro and PD-L1 positive tumors. And all of those trials showing that checkpoint inhibitor is better than chemotherapy in terms of survival. And that's why all of these three agents, nivo, pembro, and atezo, has been approved in a second-line treatment in patients who has been progressed on a platinum-based doublet, and it make it to the standard of care. Later on, we were trying to figure out which patient really benefit the most from those agents. And one of the important biomarker that came up is the PD-L1 expression status. And we have seen that those patients who are not just PD-L1 positive tumor, but also those who have high PD-L1 expression probably are the one who are benefit the most from a single agent checkpoint inhibitor compared to chemotherapy. And that's why there are more shifts to utilize this biomarker in order to select patients who are benefit the most. We do have an issue with this biomarker. It's not something that we can say a binary biomarker such as an EGFR and ALK where we have positive or negative. But here we have a kind of quantitative biomarkers. It's not just a positive or negative, but we also have a different expression of a PD-L1 positivity that's ranging from 1 to 100%. And we know that the more we move to this side, the more benefit can be driven from those checkpoint inhibitor. However, there are some patients on this side, they don't benefit. On the other half, also those who have a low expression, unlikely they benefit, but still there are patients who are benefit from those treatments. So it's more kind of a way to select patients who are benefit the most, but it's not really an exclusion or inclusion to include checkpoint inhibitor in the treatment paradigm, unlike the EGFR, ALK, and ROS1 that has been described earlier. And that's why when the data that we have in the first line is more kind of categorized in a more kind of a monotherapy clinical trials for a checkpoint inhibitor in an upfront line versus a combination that's mostly include chemotherapy or a non-chemotherapy such as a dual immunotherapy checkpoint inhibitors. One of the important factors that delineate or select each of those options, the mono or the combo, is the PD-L1 release status, whether it's positive or negative, whether it's high PD-L1 positive or a low PD-L1 positive status. And the earlier trial that we have is the monotherapy. And given the fact that we know that those patients who have a high PD-L1 positive tumor are the one who benefit the most from a checkpoint inhibitor, number of trials has been conducted. And what we have seen with those trials, there are a number of trials, and it's quite difficult to go over all of them. But the important trial that I'm gonna go highlight is the KEYNOTE 24, as well as the IMBOR 110, which is the one that really make the standard of care that we have right now. The first one is the KEYNOTE 24 that looked at the pembro as a single agent versus chemotherapy, which is a platinum-based doublet in patient who has not been received any treatment for the first line treatment. And what we have seen with this trial is if you start with the checkpoint inhibitor, pembrolizumab, and you can see that the clear benefit in terms of outcome, which is survival. And that was the updated survival data that we have at 3 years, showing that almost double median survival for those patients who have received pembro non-chemo regimen versus the chemotherapy. And this benefit is even seem to be preserved even with the longer follow-ups. So that's why pembro became a standard of care in the frontline patient, in a frontline setting, only in patient with a PD-L1 positive and high expressor as well. The IMBOR is also one trial that look at the different checkpoint inhibitor, atezolizumab versus chemotherapy, platinum-based doublet. And here also, overall, it's a negative trial. But when they look at those patients who have high PD-L1 expression, and the difference with this trial, they look at the different biomarkers. It's not just the PD-L1 expression in the tumor cell, but also the immune cell. And it's more kind of a combined score. So what we have seen here is if you select those patients who have a high PD-L1 expression, and you treat them with a single agent checkpoint inhibitor in form of atezo, you can achieve a higher survival benefit. That's almost kind of near to double, with a hazard ratio of 0.59, suggests that single agent is more superior to chemotherapy in such patient population. However, we know that not all patients, they do benefit from immunotherapy, and we do believe that those patients who did not respond to immunotherapy are more kind of having non-immunogenic tumor or a cold tumor. And there are a number of theoretical rationale, and that was created in order to see whether we can convert those cold or non-immunogenic in a more kind of hot or immunogenic tumor by a combination approach. And the combination strategy was created from this cancer immunity cycle. As you know, that in a cancer, we treat patients with different anti-cancer treatment that could be include chemotherapy, radiotherapy, anti-angiogenic drugs like bevacizumab. From the checkpoint inhibitor, we have different class. We have a PD-L1 tumors checkpoint inhibitor, as well as the anti-CTLA-4 inhibitor. What we know is if you combine this strategy together, the chemo, anti-angiogenic, dual checkpoint inhibitor, we can have a more kind of synergetic effect. By killing the cancer cell, this will release more antigen that can be picked up by those checkpoint inhibitors. Beva can help with infiltration of the T cell and the tumor cell. So those are more kind of having anti or a synergetic effect when it's combined together, and it might convert those non-immunogenic tumor in a more kind of immunogenic tumor that can be also that can expand the response that we could achieve from immunotherapy per se. So from combination approach, we have different combination-based treatment that mostly either chemo-based or non-chemo-based. What I mean by non-chemo-based are the ones that only include dual immunotherapy or checkpoint inhibitors without chemotherapy background. There are a number of options that created from number of clinical trials, including a chemo-based immunotherapy. We have chemo, immuno, KEYNOTE trials. The most important one is probably the KEYNOTE 189, and also for non-squamous as well as for squamous. We have also regimen that including Beva in non-squamous, which is the Empower 150. And recently we have the dual immuno with selected or a few cycle of chemotherapy as 9LA or the CheckMate 9LA that has been presented at this ASCO meeting this year. So the initial data, and probably one of the data that really led to the standard of care that we have right now, is the KEYNOTE 189, which is the trial that looked at the chemo combination with immunotherapy. It was mostly platinum-based doublet with a pembro versus chemotherapy alone. And here we have seen that those patients who started with a combo, they have a better outcome. 22-month median survival, 10 months in the control arm. And the benefit was seen across all patients, including high PD-L1 positive tumors or low PD-L1, and even the PD-L1 negative. All of them, they do benefit from the chemo immuno combination. In the squamous also, we have similar trend. As you know, the squamous or the chemo backbone in the squamous is quite different with the non-squamous. With the non-squamous, we include pemetrexed, but with the squamous, the chemotherapy mostly including taxane with the platinum. And by adding pembro to the chemo, platinum, taxane, we have seen that those also can add to the outcome. Empower 50, which looked at the different checkpoint inhibitor, which is atezolizumab with the chemo, immuno, as well as the bevacizumab. It's one of those regimens that have been used in some part of the world, and it's also is part of the one of the standards of care that we have also when it comes to chemotherapy. So the question with this trial is, although it was a quite complex design, but the main question is whether checkpoint inhibitor or atezolizumab can add to the triplet regimen that including chemo, platinum, Pacli, as well as bevacizumab. And this trial was positive, showing that if you add atezo to the triplet regimen, you can also gain to the survival. And that's also another option that has been utilized as well as approved for a frontline setting if you are using the chemo-PIVA regimen only for a non-squamous histology. CheckMate also 9LA also came up this year, and it was more kind of dual immunotherapy, looking at the 2 different checkpoint inhibitors, Nivo, Ipi, with 2 cycles of chemotherapy versus chemotherapy alone. And this trial also in the line of other trials showing that the chemo dual immuno is better than chemotherapy alone. And there was quite clear difference when it comes to the survival that also was seen across different PD-L1 expression, whether negative, positive, high, or low expression. All of those, they do benefit from the treatment. We do have also a non-chemo based regimen that's mostly dual immunotherapy, which is the combination of 2 different immunotherapy that either anti-PD-L1 as well as CTLA-4, and we have 2 different trials, the CheckMate 227 and the MYSTIC trial. The MYSTIC is quite negative trial, but the CheckMate is the one that's really showing a positive data. It also has a kind of a complex design that include dual immunotherapy, chemotherapy, single with the chemotherapy, but the main arms that has been compared with this phase 3 clinical trials, the dual immunotherapy, the Nivo, Ipi, versus the chemotherapy is, do the dual immunotherapy better than chemotherapy or not? And there are a number of primary endpoints that has been designed with this trial, which is overall survival in the PD-L1 positive population, or the PFS in the TMB. And the TMB is one of the biomarkers that also came up, and it thought to be quite useful to select those patients who are benefit from immunotherapy, especially in the CheckMate trials or the trial that include the Nivolumab as a part of the experimental arm. The initial data that look at one of the biomarkers, the tumor mutational burden, showing a positive result when it comes to a PFS. So patients who had dual immunotherapy, they have a longer progression-free survival compared to chemotherapy. However, with the longer follow-up, we have noticed that those benefit is really did not sustain, and there was no survival benefit that was achieved in patient with a high TMB, whether you go with a dual immuno or you go with chemotherapy alone. But what's really positive is when they look at the survival in patient who's been selected for a PD-L1 positive tumor of 1% or more, and we have seen that those patients who have been treated with a dual checkpoint inhibitor, they were better than chemotherapy. There was a third arm that including Nivo, but when you see here, the Nivo Ipi have a longer survival benefit that was 17 months compared to 14 months, and the benefit was being sustained even with a longer follow-up. PD-L1 negative also, they do benefit, although this was not the primary endpoint, but also the benefit that has been seen with the dual checkpoint inhibitor was seen either with the PD-L1 positive as well as the PD-L1 negative tumor, and the benefit was almost better than the chemotherapy, which is the control arm in this trials. So in practice, when you decide about the treatment options for a patient with advanced in the first-line setting, most of the time we have to look at the PD-L1 expression. If we have patient with a PD-L1 positive and high expressor, the preferred regimen is always monotherapy, and we have 2 options right now: is pembro and atezo. Chemotherapy-based immunotherapy is also another potential options, especially for those patients with high volume disease, since the chemotherapy addition to immunotherapy can add to the response rate, and the response rate sometimes might be important, especially for high disease burden and symptomatic patient. For a PD-L1 low expressor, still the chemo-based regimen is the standard of care. We have a number of options that include pembro or atezo, as well as the dual checkpoint inhibitor with chemotherapy. It's all of them fitting in this category. For those who are not wishing to avoid chemotherapy, the dual immunotherapy is also the back option for this patient population. For a negative PD-L1 expression or less than 1, I think the chemotherapy is the only option that we have. Still, we have seen some encouraging data with the dual checkpoint inhibitor, and that might be also an option, especially if you would like to avoid chemotherapy in those patient population. Since the encouraging data that we have with this stage 4 disease, there are a number of trials that has been conducted in a stage 3 disease in a patient where we treat with a curative setting. And one of the important trials is the Pacific trial, which is the trial that included patient who has been having locally advanced unresectable stage 3, who has been treated with a radical intent chemo radiation. And then those patients were randomized to a 1 year of Durvalumab, which is one of the PD-L1 inhibitor, a checkpoint inhibitor, and this was compared to placebo. This trial was quite positive, showing superiority of a single agent Durvalumab as a maintenance following concurrent chemoradiation, and we have seen follow-up data that showed that the benefit also was preserved with a longer follow-up. It's almost kind of 13% absolute benefit that we have seen at 3 years, and the median survival was not reached as with the last presentation that we have last year, as I recall. So in conclusion, I think immunotherapy is one of the important breakthrough that we do have with non-small cell lung cancer. It's really made it to the standard of care in advanced stage 4 metastatic non-small cell lung cancer, either a monotherapy or a combination with other anti-cancer agent that could be chemotherapy or more kind of dual checkpoint inhibitors. Immunotherapy also is now a standard of care in stage 3 disease following concurrent chemoradiation. We're still figuring out how to select those patients who are benefit the most and biomarkers. We still use PD-L1 as the best biomarker that we do have, but we are still looking for more biomarker in order to select those who benefit the most. And there's still more ongoing research when it comes to such selection and biomarker, and try to expand those options even in non-responder in the near future. Thank you so much.